Hi, my name is Matt Jones. I'm a Senior Sector Manager of the Medical and Scientific Sector at DCA Design. We are a multidisciplinary device design consultancy based in the UK, and I'm a specialist in the development of drug delivery devices, and that includes a great deal of work developing devices with smart and connected functionality. Which brings me on to the subject of today's presentation, which summarizes data that we've collected on asthma patient attitudes and preferences for connected and smart inhaler features. By smart features, I mean electronic functions, things like sensors that measure how the device is used, or buzzers and lights to feed back and guide the patient. By connected features, I mean features that in some way connect to another system, be that a phone or tablet or the cloud. This data was collected using a sophisticated online survey from a total of 166 UK asthma patients aged 18 to 75 who use a variety of medications and inhaler types. Online data collection can be a fast and cost-effective way to reach very large groups of participants, and in the current pandemic has become an invaluable tool. I should also mention, though, that there are obviously limitations with collecting data in this way, and we were careful to take account of them in the study design. So, what were the aims of the study? Why did we do it? We know that there is a massive interest in the potential for smart and connected inhalers to improve adherence and to provide data that can help HCPs to better manage their patients. When we start to explore these possibilities, a really wide range of potentially interesting features and functions soon become apparent. But of course, just because it can be done doesn't mean that it should. So where do we start in deciding what function should be included in a design specification for a smart connected inhaler? Making the right choices at this stage can translate to significant time, cost, and program risk reductions. So it's essential to start on the journey with as clear a view as possible about patient attitudes and preferences for potential features. Unfortunately, it's difficult to get hold of relevant existing data of this type because most of the data in the public domain is either focused on particular commercially available devices or isn't current. So that's why we set out to collect our own. In designing our study, we started with a hierarchical task analysis to provide a detailed and systematic assessment of treatment steps. This analysis provided a structure for the generation of smart electronic features that could potentially help patients to complete each use step more safely or effectively. Within the large range of feature variants and embodiments that were generated during this process, we identified the core principles to work with for the study. The features we identified can be grouped into 4 categories: prescription, technique, lung health, and location. And within each group, the potential features were described using very clear language that all potential respondents could understand without deep technical knowledge or further explanation. In the prescription group, we looked at features that helped with refilling prescriptions, either alerts for the patient when they needed to refill or refilling automatically. In the technique group, we looked at features that monitored inhaler technique and laid out different options for using that to guide the patient, signaling afterwards or guiding during inhalation, or reporting to an HCP how technique has changed over time. In the lung health group, we looked at features that monitored lung health, either during or separately from medication delivery, and a feature that would allow lung health changes over time to be reported to an HCP. Lastly, in the location group, we looked at a feature that would help patients to find their inhaler if they lost it, and a feature that would tell them if they left the house without it. But we weren't just interested in features, we were interested in real-world trade-offs. Another limitation of some of the existing data is that it presents lots of options but provides little or no insight into the effects of potential trade-offs. For example, if we ask patients if they would like a buzzer to help them find their inhaler when it was lost, most would probably say yes, why not? But if having a buzzer also meant recharging the device regularly, would they still want it? And this is where experience of developing these types of device is invaluable, to really understand the reality of these trade-offs in devices that are safe, effective, and commercially viable. So we presented participants with trade-offs that were organised into 5 groups. Within the power group, we explained the options of a replaceable battery, a fit-for-life battery, a rechargeable battery, and no battery at all. Within the communication group, we explained the options of Bluetooth, beacon Bluetooth, where the app needs to be open and listening for a one-time signal when the inhaler is used, straight-to-network communication, and NFC. Within the format group, we looked at inhalers that had the smart hardware integrated into the device and systems where the smart hardware was part of an add-on module that was swapped between inhalers. Within the HCP interaction group, we looked at different options for communicating information to HCPs with a system that automatically emailed data to them and systems that allowed the patient to email or show the data to their GP only if they wanted to. The last group, in-use patient feedback, looked at a number of different feedback mechanisms and features, vibration, sounders and lights, either as part of the inhaler or on the phone. After identifying these features, we set about planning the study. Shown here is a summary of the study structure. It started by determining the inhaler type and asthma severity of the participants. Then it looked at attitudes towards self-management, so preferences and difficulties in the context of their current treatment regimen. Then finally, it introduced the different potential smart electronic features and collected data on attitudes and preferences towards them. So, on to some examples of the findings. First up was a very simple rating of the different smart and connected features using a 5-point Likert scale. The graph shows the percentage of participants that responded positively to each feature in green and the percentage that responded negatively in red. The first thing to note is that the participants were very positive about almost all of the potential smart features. But when viewed at this level, there was no strong preference for any particular features. And although this positive response is interesting, in itself, it's not particularly helpful in identifying what features to focus on when specifying a device. More useful is the ranking of features. We asked participants to create their ideal inhaler by combining the 3 features they liked most. This graph shows the number of patients who added each smart feature to their ideal inhaler. And this way of examining the data starts to spread out the feature preference a little more, and we can highlight a few points. For example, prescription refill related features, highlighted in pink, scored very well. There are quite a number of other findings to draw out of this view, but in the interest of time, we'll move on to another way of looking at the data. Patients were also asked about issues with their current treatment regimen, such as their confidence in managing their condition, whether their inhaler was easy to use, etc. Their answers can be used to understand which features tend to appeal to patients with certain issues or concerns. For example, if we examine the technique improving smart features, again highlighted in pink, the patients that said they don't feel confident about managing their condition were more positive towards them than those that said they did feel confident. So here on this slide are the results from the patients that said they don't feel confident. And here are the results from the patients that said they did feel confident, noticeably less interested in technique-related features. This starts to build an evidence-based picture of a link between patient attitudes towards their treatment and their acceptance of smart features. It allows us to start thinking about tailoring the feature set of a smart inhaler towards certain patient groups to maximize value. Because these devices inevitably cost more, maximizing value and benefit is really key to convincing payers that they're a worthwhile investment. For example, this data might support the use of a smart connected training device that patients use when starting their therapy and then transition away from it to a lower cost non-smart connected device when they have more confidence. When we segment the patients that said they find it difficult to take their asthma medication from those that didn't say that, we again see a clear difference in the preference for all features. So shown here are the attitudes of patients that said they didn't find it difficult to take their medication. And here are the attitudes of patients that said they did find it difficult, significantly more positive across the board. This finding perhaps further supports the idea of a smart training device that patients use at the start of their therapy. This kind of feature preference data is useful, but obviously connectivity doesn't come without potential drawbacks. To get a more complete picture, we have to explore the potential negatives as well as the positives. Batteries need to be charged, phones need to be paired, data needs to be synced, and the devices will be more expensive. Patients were asked if they would prefer their ideal smart inhaler to their current inhaler. We then introduced the possibility of a number of practical trade-off issues and asked them whether they still preferred their ideal smart inhaler to their current device. We'd expect these trade-offs to generally reduce the preference for the smart inhaler because they're generally negative features, but some were liked less than others. This graph shows the percentage of the participants that were positive towards their ideal smart inhaler and the percentage that were negative as the hollow green and red bars. The solid bars then show the new set of attitudes considering each of the listed trade-offs, and there were some interesting findings. For example, a disposable battery that needed changing was clearly not liked, but a fit-for-life battery was considered acceptable. Interestingly, NFC was the least preferred of the communication methods, possibly because it requires an additional user step. And there was a marginal preference for avoiding sending data direct to an HCP, but this preference was not as large as we expected it to be, given the increased awareness and concern around control of personal data. So, what does this data mean and how can we use it? Well, this is our first exploration based on 166 participants. So we of course have to be careful about how we interpret the data, but we're already finding some interesting insights. It tells us that attitudes to smart connected inhaler features are generally very positive. Of course, payers don't specifically care about attitudes of patients. They're interested in compliance and ultimately in clinical outcomes. But if this kind of data can allow us to specify smart connected devices that are tailored to specific patient groups, the chances of us being able to show better clinical outcomes are improved. And in the data, we see some clear preferences for specific options within the practical aspects of a connected inhaler, power, communication, feedback, etc., that can help us with specification. There are also links between issues that patients have with their current treatment and their preference for smart connected inhaler features. We could take advantage of these links, for example, by developing a smart inhaler for training purpose patients until they're confident to do without the smart features. Alternatively, it might be beneficial to develop a common tech platform in which subsets of features can be turned on and off and offered only to specific patient groups, or can be controlled via an app. Once we know more about the attitudes of patients to these features, it becomes easier and easier to direct more effective solutions towards them. These are just the first data we've collected. We plan to collect more responses to investigate some interesting potential findings in groups that are currently too small to give significance. We also plan to modify and expand the study to take in HCP's attitudes. And it's likely that we'll be able to draw out further insights from this body of data when we interrogate it with a specific new smart inhaler application in mind. And hopefully we'll be back next year to tell you all about that. Thank you very much for listening. Please do get in touch with any questions you might have.